Hello, this is Jacob Cherian, presenting a case of transvenous coil embolization of an isolated sigmoid sinus dural arteriovenous fistula. The following case comes from the work done at Emory University Hospital in Atlanta, Georgia. A 64-year-old man was with his wife in the movie theater when he developed sudden onset dysarthria and aphasia followed by loss of consciousness. Symptoms were concerning for a seizure. At the time of presentation, he denied headache. On exam, he was fully awake and alert and had excellent strength throughout. On review of his prior history, he did reveal that he had been struck by a car and had hit his head 6 months prior. Non-contrast CT head demonstrated a small, posterior, left temporal lobe intraparenchymal hematoma. CT head angiography demonstrated enlarged and tortuous cortical vessels in the vicinity of the left temporal lobe hemorrhage. No discrete nidus was noted. The left sigmoid sinus was felt to be either hypoplastic or thrombosed. These findings were concerning for a possible dural arteriovenous fistula. Diagnostic angiography confirmed the presence of a left-sided sigmoid sinus dural arteriovenous fistula. Seen on this left external carotid artery injection is the arterial supply to the fistula arising from the left occipital artery, ascending pharyngeal artery, and middle meningeal artery. Seen here is an image from the left external carotid artery injection in the late venous phase. The left sigmoid sinus is trapped and does not drain in normal anterograde fashion. There is significant cortical venous reflux that encompasses and empties into the superior sagittal sinus. In summary, we have a 64-year-old man presenting with seizure secondary to a small left temporal hemorrhage. He reports a preceding traumatic head injury 6 months prior. Diagnostic angiography confirms the presence of a Borden type 3 left sigmoid sinus dural arteriovenous fistula. The fistula is supplied by the left occipital, middle meningeal, and ascending pharyngeal arteries. The fistula consists of a trapped left sigmoid sinus that empties retrograde fashion through significant cortical venous reflux. Given the patient's presentation with intraparenchymal hematoma and the presence of significant cortical venous reflux, the patient's dural arteriovenous fistula was felt to require treatment. Multiple treatment options were considered. In order of increasing expected difficulty, these included transvenous coil embolization, transarterial onyx embolization, and direct surgical exposure of the trapped left sigmoid sinus, followed by direct puncture and coil embolization. After discussion with the patient and his family, the decision was made to proceed with endovascular treatment. The patient was placed under general anesthesia and placed under complete heparinization. A 5 French short sheath was placed in the right common femoral artery. Access to the arterial system would allow for runs to delineate the venous anatomy in the late phase of the arterial injection. Additionally, an 80 centimeter long 6 French Cook shuttle was placed in the left common femoral vein. It was hoped that through this access, transvenous access to the left sigmoid sinus could be achieved. Here seen is a lateral projection view of the left common carotid artery injection. Seen clearly is the trapped sigmoid sinus on the left side, supplied again by the occipital artery, ascending pharyngeal artery, and middle meningeal artery. Transvenous access to the trapped left sigmoid sinus was first attempted through the contralateral side. Here seen is a Cook shuttle positioned in the right left jugular bulb area. A guide catheter, an 058 Navion, is positioned in the region of the torcula, and through this a PX slim microcatheter is positioned in the left transverse sinus before the occluded and trapped left sigmoid sinus segment. Here seen is an injection done from the left common carotid artery, demonstrating the position of the aforementioned catheters relative to the arterial anatomy and the trapped sigmoid sinus. With use of an Asahi 018 microwire, access across the blind segment of the left transverse sigmoid junction is achieved, and the microcatheter has now been successfully positioned within the trapped left sigmoid sinus. Here seen is a microcatheter injection with the microcatheter positioned within the trapped left sigmoid sinus. With the microcatheter properly positioned within the trapped, isolated left sigmoid sinus, coiling to obliterate the pouch is now performed. This is done in distal to proximal fashion to ensure complete obliteration of the venous pouch. Here seen is a left common carotid artery injection done through the diagnostic catheter, demonstrating the coil mass. Final left common carotid artery angiography demonstrates complete obliteration of the fistula. Corticovenous reflux is not seen, and the pouch no longer fills. All venous drainage is now in proper time. The patient did well following the procedure and was discharged on post-op day 3. At that time, he was tolerating a regular diet, he was fully ambulatory, and had developed no neurologic deterioration following his procedure. He was discharged home with levetiracetam 1000 mg BID for management of his initial presentation with seizure. Thank you.